with compassion. I'm Stephanie Adler-Yuan, Director of Education and Training at the Schwartz Center for Compassionate Healthcare, and I'll be your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin today's formal presentation, I'd like to go over a few details about how this webinar will work. The Schwartz Center's webinar series, Compassion in Action, is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes long. The first 45 minutes will consist of a presentation from our guest speaker, followed by a 10-minute question and answer session. Today's program is being recorded and it will be available along with the presentation slides on the Schwartz Center website, 2 weeks after this session. Please note that as attendees, you're participating in listen-only mode, but if you'd like to interact with our speakers, you can do so using the questions pane on your screen. If you have any questions, and we hope you do, please just type them into the questions pane and send them our way, and we'll address as many of them as we can at the end of the presentation. And if you have any technical issues during the presentation, let us know those too, and we'll help you deal with them as quickly as we can. Last thing is, as you exit the webinar, please note that you'll receive an electronic survey, and we'd love for you to take a minute to complete it so that we can capture your assessment of today's program. We treasure your feedback and we read every comment, so please take that minute to fill out the assessment. Thank you very much. And now it is my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is the Chief Medical Officer for the Schwartz Center, and she's an Associate Professor of Medicine as well at Harvard Medical School. Welcome, Beth.
Thanks, Stephanie, and good afternoon. Thank you all for joining us for the Schwartz Center's Compassion in Action webinar. As you know, we're very, very excited. This year, the Schwartz Center will be hosting its second National Compassion in Action Conference, and it's taking place in Boston, September 8th through 10th. We first developed the conference 2 years ago to bring together clinicians, health system leaders, and everyone else really who's committed to making compassion a priority in their organizations and in their communities. And this year is a little bit different. We have speakers whose work has inspired innovation, leadership, culture change in all of the areas that we'll be focusing on during the conference. And our series of webinars this year is also going to pick up these themes. So the themes include workforce resilience, well-being, and engagement, creating compassionate organizational cultures, compassionate responses to social challenges, communicating with patients, families, and each other, engaging patients, families, and their communities to support health, and also compassion science and practice. So we hope that if you haven't done so already, you'll go onto our Schwartz Center website, take a look at the agenda. It's just outstanding, and register for the conference as soon as you can. But today we are really, really excited to be joined by my friend, Daniel Wolfson, who is the Executive Vice President and Chief Operating Officer of the ABIM Foundation. You may know that this foundation has focused its efforts on advancing medical professionalism and physician leadership to improve the healthcare system. Mr. Wolfson has been instrumental in leading the foundation's Choosing Wisely campaign, which has been a multi-year effort to really promote conversations between clinicians and patients about avoiding care that may be unnecessary and, in fact, could possibly cause harm. Today, though, we're going to hear from Mr. Wolfson about how and why the ABM Foundation came to lead not just the Choosing Wisely effort, but is beginning an exploration of the issue of trust. And today, we're going to hear a little bit about how trust and compassion are interrelated, essential to clinical relationships, and think about ways to rebuild trust in healthcare. So welcome, Daniel. It's a pleasure to have you. And we're waiting for Daniel to come back online here onto our platform. So just bear with us while we work with some of the technical aspects of the webinar.
Hello, can you hear me now?
We can. Thank you, Daniel. So welcome. The floor is yours, sir. We're eager to hear from you.
Well, in conclusion, no. Well, it's an honor to be here today presenting to the Schwartz Center. A real privilege and honor to be here, and I've been a big admirer of your organization for many years, and I applaud what you've done over the years. Next slide. So here are our learning objectives. I really want to explain the why our focus on trust now, and why the ABIM Foundation being involved. And to begin understanding attributes of trust, and probably for the first time known to anybody, I'm going to present you a trust framework that we're thinking about and trying to build. And then how are we actually building and rebuilding trust in healthcare? It's one thing to talk about trust, and it's another thing, I think, to be very concrete and have steps in rebuilding and building trust. Next slide, please. So we have our first polling question. Have you experienced a time when trust was broken, either in a relationship or in an organization? So select one, and we'll see the results in just a moment. Well, overwhelmingly, people have experienced a time when trust was broken, either in a relationship, in an organization. So I think a lot of people can relate to this. Next slide, please. So trust in our institutions is broken. It's happening in real time globally. It's happening with politics, with media, all these organizations, and it's happening with healthcare. Next slide, please. I think a part of the deterioration of trust has been an attack on science and authority. And we see that because of internet empowering people to self-publish, personal experience being more important than expert opinion, and widespread loss of trust regarding facts. Facts don't seem to matter sometimes, and generally in society. And established institutions are having a hard time keeping up with their authority, their expertise over what's being published on the internet, and extreme volumes of information, some very good and some not so good. Next slide, please. So why a focus on trust? And we wrote an article that appeared in Academic Medicine explaining that. So we think there's an erosion of trust and an increase in misinformation, and we'll show you some facts and figures about that. And what we learned about trust in Choosing Wisely, which we thought was really developed on trusting and respectful relationships with specialty societies, with patient groups, and with the public in general. And we, this link to professionalism and trust, this actually is something that Joe Shapiro from Brigham and Women has always said to me. It's all about trusting and respectful relationships. And that to me was the link with professionalism. And connection to ABIM, who is rebuilding trust after people have questioned the maintenance of certification program, and there's been some false information about ABIM's finances. Next slide, please. So in Trust and Choosing Wisely, in that article, there was trust needed for conversations between patients and physicians on overuse. And in fact, one of the things that we're looking at with Choosing Wisely, kind of a new direction, is looking at marginalized patients and seeing their trust levels and having conversations about overuse tests and procedures. It was also choosing wisely in trust in the competencies of our partners, especially the specialty societies, and not over micromanaging the specialty societies, but trusting in the competencies of those partners and the science base, and developing a respectful relationship with all our partners, over 80 specialty societies and over 100 patient consumer groups. Next slide, please. So this is what we think about the attributes of trust, the elements of trust. And I think a big part of it is compassion. I can't imagine a relationship in healthcare, particularly with physicians, that does not have compassion as part of an important component. Not that it always happens, but it's something that we expect, particularly when we're vulnerable. And trust always starts with this notion of vulnerability. So this comes from the literature and our own thoughts on the subject, but I think you'll see when people talk about trust, they're talking about one of these aspects, but to get a full kind of picture about trust, we think about all of these attributes. Next slide, please. And then we think about the relationships. And, you know, we can start talking about patient, family, and physician relationships. We can talk about the relationships between the patient and the family and the teams and colleagues. We can be talking about relationships with organizations and practice settings. And we can talk about relationships with the external environment, be it payers, health plans, employers, the government. We are interested in learning all about all of those relationships. At this point, we thought that precluding any of those relationships was premature and that we could learn a lot, and there might be lots of commonalities. And frankly, we don't really think that we can have a trusting health system without all the stakeholders being involved in a discussion of the subject. And we're thinking about ways of doing that, and I'll go through that further on. Next slide, please. And there's measures, and we don't have a lot of measures. We have good patient, family, physician relationship measures. I have seen some organizational measures, assessment tools, not very robust. I think it's an area that needs development. Next slide, please. So that's our framework, how we think about it. But trust matters. People are more likely to adhere to a treatment plan. They're more likely to engage with healthcare innovations such as telehealth, and they respond effectively or less effectively to public health crisis. And you can look to epidemics in Africa when there's low trust of the healthcare system. What does that do? Next slide, please. So the trends in healthcare are over a large period of time are pretty low, and I'll go through some of the stats. But 75% had confidence in medical leaders. That's down to 34%. Doctors in your country being trusted, we're at 58%. This comes from an Edelman poll. Next slide, please. So, you know, healthcare does pretty well. The medical system does pretty well. But as you can see from the right-hand side, next slide, please. medical systems are the biggest loser as far as trust over that period of time. So we are a trusting profession, a trusting system, but we're on a downward slope. And I think anything like trust being unattended, you ignore it at your own peril. Next slide, please. It's just not politics and vaccinations. Of the 20 most shared articles on Facebook with the word cancer in the headline, more than half report claims discredited by doctors and health authorities. ASCO, the Society of Clinical Oncology, did a survey recently and showed a marked increase in people who believe in alternative medicine. That would be about 40% that have done alternative medicine. Steve Jobs is really the poster child for alternative medicine. He had a form of pancreatic cancer, similar to, I believe, Justice Ginsburg, and he would have been alive today if he had not gone through the alternative treatment route. But there's a lot of information on the web, and people begin to believe anything that's published on the websites. Next slide, please. And how does the world become so fake? It's driven by Facebook. It's driven by Twitter. Where do you get your news from? 70% get it from family and friends and networks. 13% get it through news journals. So we live in a different world, and facts are different, authority is different, and it all affects trust, and it all affects the patient-physician relationship. When the authority of a physician is not being trusted and the poor relationships on top of it, it causes bad care. Next slide, please. So, we're humbled by our entry into trust. We're on a journey. We're not alone on this. A lot of people can relate to this issue of trust. We're challenging to accept, but it's an incredible opportunity, we think. And trust matters to patients. It matters a lot. And this statistic proves that it matters to outcomes. Next slide, please. And so what is our overall goal? We think that trust should be a core operating principle in healthcare. One that will ultimately help advance medical professionalism, but ultimately improves outcomes and improves quality of care. Next slide, please. So, have you experienced a time when trust was broken and then was restored? Yes or no? I was going to sing during this time, but I thought I'd give you a break. Can we see the results, please? So 19% have not seen trust restored once broken. That becomes a lasting, permanent condition. Next slide, please. Thank you. So what are we doing in this area as a small foundation? Well, we had what we call our annual forum last year based on trust. We're having another annual forum this year on trust. From that meeting, I don't know if you've seen them, but there have been, I think at this point, 10 JAMA viewpoints on different relationships, and I'll show you titles, and you probably know some of the authors on this paper. We also developed something called a Trust Practice Challenge. I'm probably going to call it something else going forward. But we put out a large call, large call for us at least. We contacted our mailing list, our contacts, and asked them to come up with a practice that promoted engendered trust. And we came up with 68 and submissions, and 30 we thought were outstanding, and 8 we gave blue ribbons to. Possible future actions are, we've had 2 meetings on medical information, have not exactly hit on a strategy, but we think it's important, and we're gathering examples of organizations that are looking at how to combat medical misinformation, largely through educating reporters about how to talk about healthcare information and health information. We're thinking about expanding the Trust Practices Initiative to sectors of the healthcare system, hospitals, health plans, academic medical centers, and having organizations come up similar to Choosing Wisely with 5 trust practices that we will release together and try to spread and disseminate those. And so that's kind of a sector initiative, and I've talked to Beth about the Schwartz Center doing such activity with members, participants of the Schwartz Center. And then we're thinking also about focusing on populations with more distrust, marginalized patients. In Choosing Wisely, we're developing a network of safety net hospitals that are thinking about trying to lower unnecessary tests and procedures, and also very interested in this issue of trust. And we're developing a network to do that. Next slide, please. And here's some of the titles through some leaders, and I'll point one article out of some authors that you probably know. One is this Physician Trust in One Another by Richard Frankel and Tony Suckman and Virginia Tilden, who is a RN PhD. It got as you can see, the numbers, it did pretty well. I thought it was a very courageous article actually to think about. And you can always talk about the team, and that's important. We know it's important, but how physicians interact, particularly across specialty lines, is really important and doesn't get addressed enough in our estimation. But you see distrust with building trust in clinical organizational relationships. You might know these Boston-based authors, Mary Jane Klanacklia and Jack Silverson, and so it's been the beginning, I think, of a conversation to have it in a high-impact journal, and it's, I think, started a conversation about this notion of the importance of trust. Next slide, please. Okay, so how important is trust in developing a compassionate environment? Very important, somewhat important, not important. So people think it's pretty important. 93% said it was very important. So I hope we'll have a discussion how it relates, how it doesn't relate, how it encompasses parts of it, but not all parts of compassion. And I look forward to that conversation. So this is our Trust Practice Challenge, open call to identify and promote existing practices that foster, promote, and engender trust in healthcare. And we got a lot of interesting responses. Next slide, please. So I thought what was interesting is how they clustered together. We didn't set out this framework initially, but I began to look at submissions and thought about clumping, and they clumped around this. So I thought it was pretty interesting. The one that got a lot of submissions in that category was the patient-centered design, but knowing your patient, conversations and support were really about support of the team, with the patient, but it was more about clinicians and staff having conversations, supporting each other, particularly as they go through difficult times with sadness and tragedy that happens every day in healthcare. Misinformation, a lot about the Sorensen Institute, I think is in Boston, where they educate reporters on healthcare issues and how to talk to them. Leadership was another one that got a lot of interesting submissions. One notably from Mayo, a leadership or a leaders index that is used to give feedback to healthcare leaders about their style, how they give feedback, how they're supporting their people, and then transparency and value and affordability. So I thought it was interesting how they clustered. So next slide, please. So just three outstanding entries. Use of graphic medicine comic strips to improve patient-physician engagement. So everybody talks about EHR as, a burden, and I'm sure it is. But at the University of Chicago, they want to turn the computer screen around and have both the patient and physician looking at it when the physician is filling out what they need to fill out. And the comic strip is something that orients the patient to how to interact with the EHR and how to interact with a physician while they're doing that. If I know not a lot of people read this, but in Modern Healthcare, there's a good description of that, and actually shows the what is called computers in the clinic, your role. The ABC is ask to see the screen, B is become involved, and C is call for attention. When you have something sensitive to discuss, speak up and ask for your doctor's full attention. In Des Moines, Iowa, a dedicated clinical program for the LGBTQ community. I think a good example of heightened sensitivity to a marginalized who feels marginalized and is marginalized. And so, the example of learning the use of different pronouns, etc., was a really outstanding. And then the last one was shared data collection, something familiar to many, reporting on clinical performance in a very public way. Lots of transparency involved in that. So these are three examples. The compendium of 30 will be on our website shortly. I have written about several of the winners. I think I've written about 6 or 5 of the 8 winners, and you can read about those on the abimfoundation.org website. You can also follow me on Twitter on WolfsonD. So next slide, please. More trust will improve in healthcare. Regaining trust in healthcare demands humility, vulnerability, all of these things to really regain it and to build it, which I think is more important. Next slide, please. Conversations are difficult to have in a way that builds trust. In environments with low trust, those conversations are even more challenging. So I think that's my last slide, and I want to thank you for your patience and look forward to your questions. Thank you.
Thank you, Daniel. Thanks very, very much. It's really interesting and provocative, I think. I'd like to, pose some questions, and we have a couple of questions from folks in the audience. One question that did come in was from somebody who is an analyst of adverse events and consumer feedback, and wondered about the role of trust in these two areas, adverse events and consumer feedback on them. What do you think?
I don't know of any data on trust in adverse events, so I'd love to see any data on that. We know the importance of the patient-physician relationship and the trust factors about that. Dana Safran did a lot of work on that and did see a strong correlation between positive patient experiences and trust in the physician. And we know that malpractice often relates back to communication skills and the relationship between the patient and physician. So I gotta believe it does, theoretically, but I don't have data.
Sure.
And now the next question was what, Beth?
No, I think that was it. I mean, I think the person was wondering about how trust might feed into really the whole notion of consumer feedback on adverse events. I mean, I guess I would assume this is really actually an interesting concept of consumer feedback on adverse events, that perhaps if there was an open forum to actually promote that, it might promote trust because it's promoting transparency, which is part of your framework.
Right. And I got to think that relates to the trust in the organization. And, what I think is going to happen over time is that as physicians become more aligned with organizations than they were in the past, it's not going to be just their relationship with the patient that's going to be important. I think it's going to be important, their relationship with, or the perception of the organization. Does the organization have my best interest? Is there conflicts of interest, for instance, in the institution that would make me think that there's deterioration of my trust in my doctor? And I think that's an area of research that needs to be explored. How does that happen? There's been a huge conflict of interest case in New York, and will that spill over to the patient-physician relationship? And I think that's going to be very interesting to see that.
Yeah, can you speak to, I know you've been speaking a lot about physicians, but we work in teams now. So how do you fit this into the general conception of team-based care?
Well, so I think that the trust among team members, the respect, the relationships, how the interaction goes, is at the essence of good teamwork. So I think it has a huge factor in the quality of care coordination. Do I trust that person to do what they say they're going to do? The reliability factor, the competence factor really comes into play. And I think that those are all, I think, attributes of trust. If I can't rely on you to do what you say you were going to do in the team, if I don't think you're competent to to do what you say, I think that has tremendous effect on the quality of the teamwork.
Yeah. I'm wondering too, and maybe this gets into your notion of transparency, but if there is trust in an environment that promotes honesty, respect, mutual trust, mutual engagement, it might be easier for people to speak their minds, even up a authority gradient, which might also play into the concept of trust in teams. We have a lot of questions here. Oh, go ahead. What did you want to say?
No, I think leadership sets the tone of the organization. If it's extremely hierarchical and there's not a mechanism for information to flow freely, I think it has a tremendous impact on the culture and trusting relationships. I really do think sometimes trust starts at the top.
Well, I think it's interesting that you say that relationships are built one by one, but each small relational act builds a collection of expectations that then becomes a cultural norm. Yep. And I think that's actually very, very true. So let me read to you some of these other questions. I feel like I'm hogging the question pane here. Did you have one more thing you were going to say, Daniel, before I read some more?
No, I think as Dan Duffy used to say to me, Daniel, it's organizations are not brick and mortar. They're a bunch of conversations that happen, and it's a bunch of relationships. That's what organizations are. They're not anything but that.
Yeah, that's exactly right. We are the system. We're not external to systems or organizations. So one person asks about any recommendations or research about trust in the nursing profession.
Well, I only know one little factoid, that nurses are trusted more than physicians or anybody in the healthcare system. That's the only factoid I know. And
right. Exactly. I'm aware of that also, and it'd be very interesting for this person who's asking this question to do a little bit of a literature search and see if she wants to get back to the Schwartz Center about what she's found.
Yeah. And we're in conversation with the American Academy of Nurses, who also participates in the Choosing Wisely campaign, about the trust practice effort that we'll do in the future.
Well, that would be terrific, actually, to combine forces so that it really becomes an interprofessional effort. I think that would be terrific. I
don't make mistakes twice.
Well, then you're better than most of us.
We were criticized for that with Choosing Wisely, and
interesting. Okay, well you've learned
we're not going to do that. We're not going to do that again.
Yeah. Okay, so here's a whole bunch of other questions. There's a lot of questions here about measurement here, measures for trust. I don't know if you have a biblio or anything, although I would say to everybody who's listening that you could go on the ABIM Foundation website. I'm sure there are going to be resources available on the website. Daniel, is that true?
No.
People looking for information or articles.
We're in the process of gathering surveys. There's not a lot of assessment tools out there. There are there's 3 that are out there for the patient-physician relationship. One by Dana Safran, and then there's some scattering ones around organizations, but they're not very comprehensive. They'll take, confidentiality and reliability and another attribute, and that'll be it. And it doesn't seem very fulsome to me as far as the measurement. So we are lacking in measurement. Of course, sometimes we're lacking in measurement and overuse, and sometimes that's a mixed blessing. we have the tyranny of measures. So
Yeah. Well, but that's an area for development and for research.
Absolutely.
Yeah. So here's another question. How can apologizing for human error or system error build trust?
Oh boy, the apology is one of the most potent trust builders there is, in my estimation. And there's the book on apology and how to do an apology, and I'm sure people on the phone are familiar with that. But I can't think of a better trust builder than having a policy that is very transparent about errors. Joe Shapiro from Brigham and Women had a submission connected to that and connected to supporting physicians who do reveal to their patients mistakes, medical errors, and the support that's needed to do that. So very, very important. And the ABIM is a good example of an organization that did apologize. And I don't know if they were rewarded for it or not, but they did come out in, I think, a bold way and withdrew the quality improvement effort requirement, I should say. And I thought it was well respected and well received by many. Others maybe not. But I think it was bold, and it was done in a way that I thought was very professional.
Yeah. So for those who may not know, there was a perception of conflict of interest with the ABIM, and the new CEO, your boss, issued a public statement about it, which I think did go a long way to rebuilding trust in the organization. It's interesting. Something's occurring to me, though. The book you're referring to was by Aaron Lazar, The Power of Apology.
Yes. I have it on my shelf. Thank you.
Yeah. But it's interesting because I think without saying how things are going to be done differently, it's possible to trust the person but not trust the system or the organization to repair whatever systemic errors led to the error. The question that was asked was, can apologizing, or how can apologizing for human error or system error build trust? And I think it requires that other piece of the apology of telling you, how a thing's going to be done differently as a result of this, whatever it was that happened, the error that occurred.
Yep.
So anyway, here's some more, lots and lots of questions here. I think this is interesting. Can you speak to the interaction between humility and trust? It seems to me there's a line where up to some line, humility builds trust in the clinician, but past it, could humility somehow alter perceptions of competence? That's interesting. To what extent does humility, or saying I don't know the answer to that, does that build trust, or does that lead to perceptions of incompetence?
That is really a great question, and the word that comes to mind is authentic to me. Is the physician really being authentic? And I think physicians, frankly, oversell what they can do and what they can't do. And I think patients would appreciate a kind of honest, authentic answer, and not think that physicians can cure it all, that they have all the answers. And I think when we don't have humility, I think the patient is just going to be more disappointed when things don't go as prescribed. So I think it's a great question. but I think humility is a trust builder, and non-humility, I think, in the long run, is a trust destroyer. Um, in choosing wisely, the benefits of tests and procedures are overestimated, and the risks are underestimated, and I think that causes a lot of trust issues. I think surgeons, for instance, give probably everybody's had the experience. The healing time, the recovery time is always underestimated, in my estimation. And that that doesn't build trust. So so I think humility is really important in all kinds of relationships. And who wants to be around a person who is not humble? We want to stay away from those people. I certainly have run across humble people in my life and found it very irritating, and don't want to be around them. I just, particularly when you get older, you realize that we don't have the answer, and we should be humble about it.
Yeah. It is an interesting question, though. Again, it kind of reminds me of the thinking about apology. It's good to apologize, but then to explain also what is being done to avoid a similar error in the future. With this notion of humility, or maybe saying, I'm not sure, I know the answer to that. First of all, it's a little bit about, I don't know if I can answer your question because I lack the information, or because making the distinction between that and the information is not known. We have no data about this, question that you've asked. That's very, very important. But let's figure out what we're going to do to try to get the best possible information available. Again, it's sort of, how do you move forward from that position of not knowing, or from that position of, in the case of apology, having made an error and explaining what's going to come next. I think that's where trust gets built, where somebody knows they can count on you to go the extra mile to try to put their interests first, to try to really be of help. So let me just, a lot of people are asking again about your framework, and can you put the slide back up about the actions needed to rebuild trust? I will say that all of this is going to be archived on our website, and so you'll be able to see those slides on our website, on the Schwartz Center website. It should be up certainly within 2 weeks. So if you want to take another look back, that will be where you can find it.
Love to hear feedback on that framework. It is a work in progress.
Yes. This is interesting too, Daniel. Can a culture of communication be fostered by psychological safety without vulnerability? Resilience and vulnerability are sometimes at odds. Let me read it again. Can a culture of communication be fostered by psychological safety in the absence of vulnerability? It's hard for me to understand how you can have such psychological safety without vulnerability, though. And the further comment is, resilience and vulnerability are sometimes at odds.
Resiliency and
vulnerability are at odds at times.
Well, Beth, you and I have been to leadership courses, and sometimes the paradigms, we have to hold both of them, and not in fact resolve them, but hold both of those concepts of being resilient and vulnerable at the same time. So that's how I would think about that.
Yeah, I think I would agree. It is the holding of the tension and the paradox between them, and And again, when we think about what are the kinds of conditions that promote compassion, that promote trust, they are those cultures that permit the holding of paradox, that don't require polarization, that don't require opposition, in terms of not accepting that conflict and disagreement and different points of view and perspective are what contributes to our mutual learning.
Right. But the importance of psychological safety is really important for trust. And for people to, if they don't feel like that, that they can speak their mind, they can show different aspects of who they are. I don't think you can have trust. And many of the trust practices, they were trying to build psychological safety, safe spaces to be able to speak about their experiences and their relationships and their challenges.
And to trust that others will accept you, your person, your views, and accept, forgive me if this sounds funny, but really to accept our common humanity, that we're all striving for similar conditions to be able to really enact our calling that brought us to our work. Whatever has called us to do the work that we do, those are the conditions that we need to flourish.
Yep. I mean, simple things. Hannah Sherman was submitted several trust practices that Beth, like check-ins. A check-in is before you probably know this, and I'll repeat it just briefly. But a check-in is when you say to you go around the room and say, "What is holding you back from being totally present?" That's a totally different kind of question. It gets to the fact of being personal, that you do have a life outside of work. And then a checkout is, what did we do right? What did we do wrong in this meeting of reflection? And those the power of a check-in and a checkout, I think are really powerful and really do, I think, build a different culture and a different trust between people who are working together. And it's simple things like that that develop the psychological space, like I am tired. I am tired because I was up all night with a sick kid. And if you didn't know that, you think I'm just putting my elbow on my hand on my face, because I'm bored. Well, I'm not bored. I'm tired for a reason. And so I think that, the sharing, one of the check-ins that we do also is, what are you most proud of that you did, during the week? And let's celebrate that as a group and reflect. Just a point of reflection. Not doing business for a second, and just reflection. I think builds a different environment that breeds trust.
Yeah, just a moment of pause and appreciation. I agree. We have time for just one more question. And to your point, since you just gave one small suggestion about something that you could do really at any time. You can go back into your organization and do this right now, just taking a moment of appreciation or inquiry. This person asks, are there particular actions that a small organization can do to foster greater trust among the staff? I know it's a huge question for a minute left, but you want to take a crack at that?
Well, I would say that a facilitated conversation among the staff, what's going right here, what's going wrong, and kind of passing the stick around for everybody to talk, breaking down the hierarchies of organizations where people can just speak their mind. No business, just, how is this job going for you? How is the experience of working here? What's going right? What's going wrong? I mean, just off the top of my head.
Yeah, I think, again, it's about taking a moment to acknowledge the person and their contributions and their unique gifts that builds not only trust, but builds great organizations and demonstrates strong leadership. I agree. Well, I think that is all the questions that we have time for. We got an awful lot of questions. And I think that's a good sign. I'd be interested amongst those of you who do Schwartz rounds out there who are listening, whether or not you've ever done a Schwartz rounds on the issue of trust or lack of trust or, the faltering of trust. I know that I have done a Schwartz rounds on that topic more than once, but it'd be interesting to learn from you if you'd be interested in sharing your experiences with that topic. So I'm going to turn this back over to Stephanie to wrap up the program for today. Steph?
Thanks, Beth, and thanks, Daniel, for that fantastic presentation. I agree, Beth, that was absolutely more questions than we've seen pop up in any webinar in recent history, so the level of engagement was really excellent, and I think your messages really resonated with people, Daniel, so thank you so much for that. And again, just to reiterate what Beth just said, if you are a Schwartz Center member and you've had a Schwartz Rounds about trust or you'd like to talk about doing so, just reach out to me or to Kathy Scopin, and we would love to partner with you in that effort. And for the rest of you, I just want to thank you all for joining us today. We hope you enjoyed this webinar, and we hope you'll join us at our upcoming conference. I want to note for those of you on the line that we do have a promotion running right now for registration at the conference. And if you enter promo code SUMMER19, all caps, SUMMER 19, there will be a discount on registration. We also have discounts running for our member organizations if you're affiliated with a Schwartz Center member, and for Schwartz Center member teams who are sending 4 or more people, we have an extra special discount for registration. So check that out. You can take a look and get more info at compassioninactionconference.org or on the Schwartz Center's website, which is theschwartzcenter.org. So that's it for today. Thank you so much. We know how busy everyone is, and we really want to thank you for joining us today. And if you could just take a moment to complete our exit survey. As I said earlier, we love your feedback and value every bit of input from you. So thank you very much to everyone. Thank you to Daniel. Thank you to Beth. Thank you to Anna on the back end, and have a fantastic day.